This case number 2, little unusual in the sense 80-year-old patient, progressive dyspnea, and has over the years found to have aortic stenosis, which has progressed to moderate to severe AS now, with also moderate to severe AR. So this is the case with both AS and AR, and therefore doesn't make a full criteria of AS point of view, but we'll show you that echo as well as hemodynamics and valve was quadricuspid with a normal ejection fraction. So I don't know, maybe we'll ask somebody. We actually have one time unicuspid valve, quadricuspid. I don't know the incidence of quadricuspid.
I have not seen one in my career.
I have seen one unicuspid. So this is a second abnormal, bicuspid, tricuspid, forget it. But we have one unicuspid about 10 years ago. And this is the quadricuspid. The patient has both moderate to severe AI. Catheter coronaries are normal.
Yeah, normal.
Yeah, coronaries are normal. And we'll show, Lucy Safi will show the live echo, if we can show it, and then we'll go to the hemodynamics.
All right, so here's our live echo. In our parasternal view here, you can see mild
A
LV,
little louder, yeah.
We're
mild
good. We hear very
LV
well.
hypertrophy,
Okay, good.
and moderate aortic insufficiency on color Doppler. You can see there's very minimal tricuspid regurgitation. And then very lovely here is our quadricuspid valve. You can see that beautiful cross sign. And then the central aortic insufficiency.
Wow.
On freeze frame here, you can see that beautiful cross for the quadricuspid valve. Overall, normal systolic function of the left ventricle, that moderate aortic insufficiency, and now our gradients. You can see that steep incline of our aortic insufficiency Doppler. Your stroke volume here is within the top normal range, and then your mean gradient across that aortic valve for the mixed valve disease is a mean of 24. No pericardial effusion to start. That's our echo.
Okay. So clearly, and now with the CT.
Yeah, so CT, you can see small annuli, 20 millimeter on average, and you can see small alveoli, a little bit of calcium at the annulus and alveoli. Next slide. So here's the quadricuspid morphology. You see that on the CT, really beautifully shown that correlate with the echo that Lucy just showed. And this is something that is very uncommon and unusual, obviously. So it's quite remarkable to see that. Next slide. Sinuses are big. You can see that, no issues, not much leak on the calcium, which we saw. Next slide. You can see that here, the root is pretty generous in terms of a left main obstruction risk standpoint. Next slide. You can see that here again, quadricuspid commissures. Access, person, you want to comment?
Sure. Calcified posterior wall, but otherwise there's no calcium on the anterior wall. We used the right side as the main axis. Ultrasound was used for obtaining access.
And looks no trouble.
No trouble, yeah. We did two pre-closes, yeah.
So we still, I know Samir said that they use one pre-close only and sometimes put an angioseal. We are still routinely going 2 pre-closes, correct?
We do 2 pre-closes unless the vessel size is small or there's actually a significant amount of calcium, and we tend to use another closure device with another mechanism on the way out, such as an angioseal, if we don't achieve hemostasis.
I said then only. So yes, we do some cases, and I know we are the part of the Mentor trial, which has a very Sile and Gilbert are the.
And George is the PI, but yeah.
And George, yeah. So basically, now this is the case of medical necessity for mixed AS and AR, and wanted to show the hemodynamics. Can we go to the hemo, please? Look at this. Why this case? To me, I think it's the more AI than AS.
Yeah.
Look
Wow.
at this is the hemodynamic. Look at it.
Pressure is 160 over 35.
30.
Yeah, something like that.
A very, very classic
That is why
Picture of
she's
chronic
so
AI. Well, that's why the jet was also relatively smaller than expected. The pressures are equalizing rather quickly, not a lot of velocity there.
Perfect. Go back to the fluoro, please, now.
Yeah, we'll show you the aortogram. I mean, the views, implant views, and also the arch angiogram, why we could not use Sentinel. So
this was, I think we did a coronary angiogram today, non-obstructive, almost normal.
Yep.
Cameral fistula, big cameral fistula.
Oh, that's all they have. Okay, here.
that's the free cast view. Yeah. But we can actually get a cusp overlap here despite being quadricuspid. And you can see the next slide being the arch angio. So very calcified. So
Well,
we did not want to.
Yeah,
Right. I know
there's
Samir, would you have tried it at Cleveland Clinic?
a lot of calcium and tortuosity, the
Yes,
great
I do.
vessels. I don't know.
Yeah.
Samir, what do you think about the great
They are
vessels?
very big on that.
Agree.
Cerebral protection. Would you try
Yes,
advancing in this anatomy? We needed your personal opinion. Your
I would,
because
yeah.
Raj is not there. Yeah.
I would, I don't even do an angiogram, but I just look at the CT scan, but I would definitely try in this one. But again, this patient is does not have much of, we are treating mostly AR, mixed valve disease, and not much calcium, so maybe risk benefit is not in favor
Yeah.
of putting a sentinel device because the aortic valve is not super calcified.
Yeah.
Although you could argue that the aorta calcification is as
Is
big
more
a risk,
important.
if not more so, based on the early data on
Yeah.
hits.
Right, but the distal calcification, I think, beyond the
Yeah, the arch is calcific
Yeah, but
beyond
Where you
the.
see it, it means it's there further too, I'm sure.
So-
Pressure come down a little for us. Yeah. it's
Great,
160.
there's a
Oh,
very
no.
wide pulse pressure and extremely low diastolic blood pressure here, which correlates with a very significant chronic AR. LV, also you can see on the dilated side, that's why the LVDP is also under 20, as we saw.
And please keep showing the hemodynamics on one side of the screen.
Yeah, that would be great. Yeah, we don't need to see the axis. Instead of the axis, give us a hemodynamics on the left side, please.
Yeah. Yeah.
Yeah.
So it will be
So we're
just
getting the
the-
valve now. We're not going to pre-dilate here because you see there's not much calcium
Yeah.
mixed picture, but we might post-dilate if the valve looks underexpanded on the fluoro.
So sometimes, because of the vascular impedance, even after you
Yeah.
replace the valve, the diastolic pressure may remain low because some of this may be just calcification of the vasculature.
Okay.
So you can see flush by 3 o'clock, hat marker out of the curve. I think everyone pretty much familiar with the FX technology now. Since it was launched last summer.
Yeah.
So we put the picture down, the non, and then we're going to go to the cuss overlap view.
No, this was very, very easy, at least appearing very smooth crossing of the arch, of the
Yeah.
calcific arch. All right, what is a pigtail? The pigtail very often gets entangled.
Yeah.
You have to
Little part,
re-advance
please.
it. Re-advance it
Good. Okay. Okay.
later.
Little high. 150.
Inject.
Good. Very good. Okay. Sydney, inject. Push forward. Okay, 100, please. Push forward, push forward, push forward, push forward. Okay. Push forward.
Yes, no? And down.
No, push forward. No. Good. It's good. Don't do anything.
You don't want to pull the pigtail?
Yeah. Good. Okay.
See
Let's
that?
take a look here.
Take a picture with a little
Inject.
push.
You agree?
Inject.
Looks good.
What's everyone think? I think it looks great.
Very good.
I think
Anyone disagree?
Any tips and tricks about commissurial alignment to avoid the post?
We'll talk after. We'll talk afterwards. Let us release the valve first, and then so we pull the wire back, and then Dr. Kinney is going to apply a little gentle forward 150 because not much calcium. We don't want it to move.
Yeah,
You can already
Okay, so
see
we
how
keep
the
the pressure a
diastolic
little.
pressure is
Yeah, we do a
increased.
slow release.
a little push, yeah.
Very slow release. Yeah, he's pushing. It's very slow. Good, excellent. Looks good. Okay, 120.
Wire back.
Yeah, wire back. Looks very good. Advance the wire now.
Sure.
We'll do hemos. Advance the
Yeah.
wire out of the curve. 100.
Get the pigtail ready.
Maybe go to less magnification so we can keep the wire down easily.
Good.
Yeah. Yeah.
Okay. Yeah, back up.
Come down.
Yeah.
Okay, let's do the pigtail.
Okay, so this is let's go to a cuts overlap view to show the audience. Looks very good, actually. Mag in now. Good, actually looks great. So you can see the C-tab is in the inner curve. One dot in the inner, so I think it's good commercial alignment. Pick up.
and tell us that how would you do the commissural alignment. That's the
Look at that, perfect. 2 and 3. Okay, good. Well expanded. Okay, let's do the echo now, please. Okay, let's walk this out. Let me hold the sheath. Floral?
Wait.
Yeah, floral.
I'll see, wait.
One second, then we'll exchange with a pigtail.
All right, any comments from the panel regarding
What's
the...
that? Okay, now I'll answer your question, sorry. So you can see the head marker should be facing you with the cuss overlap view. That's always been, it's like Pro Plus, but FX now is easier to do. And if your head marker is on the inner curve of the descending aorta before you go to cross the arch, you need to rotate it to the outer curve to maintain that. So, and the key is try to get the dots, and we'll show that. See, look at right now there. Well, Hafiz show the echo. We can show you some floral images.
Keep going.
I'll just show it here. Okay, so here, so here you can see the head marker is at the inner curve. I mean, it's facing you. So if the head marker is away, is on the inner curve, that's not good. And so the dot, you can see one dot is facing the right side of the screen. That's promising, but it's not absolutely necessary. You can see sometimes it's more symmetric. But the key here, and we teach it to everyone, all our fellows, 2 of the 3 dots have to be below the annulus. So you can see that only 1 is a little higher, the 2 are below, so you know you didn't miss the annulus. And you can see here, the FX is much more symmetric. It's about 4 to 5 on the left, and then you can see among 3, the dots are very nice to tell you what the depth is on this view, LAO view, and we pull back the wire and we release slowly, as you saw. And this is the cuss overlap view now. You can see pretty much stay where it is. It didn't go up, it didn't go down, despite not much calcium with this case. So we're very happy with it. How does it look, Lucy and Hafiz?
So far it looks great.
Speak up, please, Lucy. Sorry, I couldn't hear you.
So far it looks great.
Yeah. We have a pigtail across, right?
Yep, there's a pigtail across. There's very minimal posterior. Looks
I
great.
think we can leave it.
Leave it.
But if you have to post dilate, what size? Tell the audience what will.
I think it will be 21 true, if I'm not mistaken.
Anyone here would
Yeah.
post dilate?
I mean, I think it looked a tiny bit constrained still at the annulus angiographically,
Yeah.
but you don't have AI, you don't have much of a PVL, so I think you don't need to.
Yeah,
It'll
there was a little
probably-
bit of an appearance at the base.
Yeah, it may still
Indeed.
expand a little bit
In
over
the-
time.
In the cusp overlap view, the very base was a bit, was an impression, but I mean, the result is good. Maybe I don't see anyone here who is enthusiastic about post-dilation.
I think you have to wait.
Yeah, and it's also the 2 millimeters already, but small LVOT. And remember, there's annular and LVOT calcium, right? So be careful what you wish for. There might be reason for that small trivial PVL.
Take the echo is done. Out.
Yeah.
Okay, go.
Yeah.
Let's go. We do the hemodynamic. The diastolic pressure, which was 40, 35, 40 is right now 60. But we're going to show that hemodynamics now.
Yeah, that would be great.
Mean gradient on echo 6.
Yeah.
Mean gradient is 6 on echo, so that's very
Gradient
good.
echo 6.
Good. Yeah. It's
And AR
on the
index,
inner.
if we take, let's see
Just be careful.
from that point of view also.
Yep.
Pigtail has to go down.
The pigtail ones. It's caught in the inner. Yep. Yep. Good. Okay. All right. So let's do some hemo and 0.
Flush.
In the meantime, I'll show the audience at the coplanar view, which is 17.1. So we have to look at the CTAP as well in terms of how inner it is. That's kind of our preference to do a dry CTAP 2 views to really check the alignment. With this, we typically never needed to do any whole CT. We can actually go back to the pre-CT to register. And you can see the CTAP is the inner curve, around between the 2 to 3 crowns at the inner, so you know that it'll be excellent alignment. Now this is a quadricuspid, but obviously it's hard to align with 3 to 4. But at least we can see it well enough to should be the left main should be okay. So here's the final result. You can see the guy.
No systolic, diastolic has gone up, but still low.
Yeah.
And maybe still there is a little bit of leak, parallel or central, maybe because of the pigtail. We'll pull it out and take another aortogram. Anu?
Well, the
Just,
valve were...
aortic compliance. Yeah.
Yeah, it could be just compliance too, right?
This is
Right
what
now.
I was expecting because in the initial aortogram
inject
didn't show
with
that
this.
much AR, so.
Yeah. Good. Let's do the aortogram.
Let's do high-quality aortogram. You want
quality. Give a little more diet.
this view of the other view. Just in this view,
No, you
where
don't
the
need
spine
different.
overlap, we
No,
don't see
different
very
view.
well.
No, this is the different view already. Use different view. You saw it was cuts overlap. This is one more complete view.
Yeah, just show a little bit more. Yeah, show the LV a little bit more. That's what I meant. Yeah, good.
Okay, ready?
Yes, focused on the,
Yeah. Okay, everyone good?
Okay, ready.
Go.
go.
It's there.
So it's a little bit there.
Should we post diet?
I would post dialect, because you have
We
good
can
conduction,
post, yeah.
you have
Let me
good
do- just,
conduction, good height.
Let me
21
look.
or 22?
No, let me know.
Now. Picture.
21 true.
21 true, okay.
Go slow because the LVOT is smaller with the annular calcium, the LVOT calcium. So
Interesting.
I would do it in the cuts overlap view again.
I think by echo, the AR was a bit underwhelming. I think somehow this was a little bit of a surprise.
Not really.
I mean, we did not pre, there was annular calcium, right? So you just recross.
I think you have room to post dilate.
Get the J wire also ready.
Yeah, okay.
Yeah, it's it's on it's 2 millimeters already on the cuts overlap view. You saw, right, Howie? So we have
Looks
to
a-
be careful, make sure the systolic pressure is low. Because remember, this is a mechanism AS-AR. We fixed the AR, okay? So, and the AS obviously also been fixed. Now, there's some residual PVL. I mean, definitely it's better than baseline. So clinically, the patient should not feel a difference with this kind of AR. But if you want a perfection, you can do that. But you have to be mindful of the risk of, root injury, right? Remember, there was a bit of a calcium at the annulus and LVOT. And LVOT is smaller. So I would go slow on the
21.
the inflation of the balloon.
But calcium is not that,
It's not prohibitive, but it's there.
Yeah.
So just something to keep in mind, right? Especially for, not for the faculty panelists here who do a lot of cases, but for those who might just be starting our program that, we always say, you don't want to have a root rupture, which is a very emotionally rich experience. And definitely people will know that they have a scar versus people will probably not know much of your mild PVL. So.
You don't have to oversize very much either. You can get away with a 20.
No, we're not. This is the mean diameter of the annulus is 21.
Yeah.
So you could argue we could go even 20, but I'm not sure 20 will touch it.
Yeah.
LVOT is around 19 point something.
I think it does. And sometimes it just needs to push open the cage a little bit. It doesn't have to actually.
No, I agree with you. The waist is well expanded, as you saw. It's just more the inflow part of it.
Yeah, 100% is the very last few stretches, just a little bit pointing inward, slightly inward than anything else, was just this appearance.
180?
Okay, we're going to post dilate now.
Okay, slowly we are going up.
No.
Make sure you go a little bit more in.
Okay, go.
Good.
Go. This one you can go fast.
Okay,
Go slow.
that's it.
Full.
Yeah, full.
It definitely expanded more down there. It definitely did.
Looks better.
Good. Get the picture again.
Okay, off the pacemaker. Yeah, very good.
No.
Off.
Stop the
Yeah.
pacemaker. Yeah, good.
Okay, so what we are going to do, knowing that the diastolic pressure and we just do the aortogram, I don't think we need to do it. Let's do the picture. Yeah.
Just veniogram.
Yeah.
Let me just take this.
Yeah, the audience is very eager to go for break. We have 1 minute.
Yeah, we are on time.
Yeah,
On time.
this is a first. This is a first, Dr. Sharma. We're on time, and in going to the break. Usually we eat half of the break.
Gilbert prepared everybody. Guys, girls, don't be over. Every on time. So I say, okay.
Dr. Sharma, in terms of...
Much better.
Yeah.
Much better. Go on.
In terms of valve selection...
Okay, go ahead, Hafiz.
If you had Gina valve available in your shelf today, would you choose for this case?
Yeah.
That's a great question, but Jenna has free commercial, wings, and this is a quadricuspid valve. So I don't know how you would orient it, but also right now, as you know, the trial was only for pure AR patients. This one, if you look at the CT and look at the echo, there is some fibrotic component, which you saw the gradient today was valve area less than 1, was 0.8, 0.9, and mean gradient of 23. So I'm not sure if this patient would have qualified for that trial, but certainly commercially, if you have a tri-leaflet valve, this this could be a potential option. And in fact, in Europe, they are doing some of that in stenosis AS patients as well.
Combined. All right, with that note, we exactly finished at our 10:45 and go for a break, and then we reconvene at 11.
No, very well, very well. Thanks the entire panel. We're going to have a nice break and we reconvene here. Moderator Anita Askar and faculty for mitral valve intervention sessions. Have a nice break.
Right.